Thank you for this invitation to present at this meeting, and it's an honor to be amongst this distinguished group of speakers. So these are my disclosures, none relevant to this presentation. So we'll start off by discussing the index lesion concept, one which has been proposed based on the observation that many patients, despite having multifocal disease, will often have one dominant lesion, which is largest and or highest grade, and with which the adverse pathologic findings such as local invasion are associated with that index lesion. And if there are other lesions, then they tend to be small or low grade. As far as metastatic risk, the index lesion may also pose the highest risk and frequency of developing metastases. So one critical question would be what the relationship is of the index lesion to these metastases, because that is often the critical determinant of prostate cancer survival. So there are a couple of rapid autopsy studies which have examined this question, looking at patients who have metastatic disease and then performing genomic profiling of the metastases and matching those with one or more of the lesions within the prostate primary. So this is an example from this one study. So this patient had multifocal disease as seen on the whole mount section above, but the T1 lesion, as it's called, is the index lesion or dominant lesion. And when they evaluated both IHC as well as genomic clonality, that one lesion did match with the seminal vesicle invasion as well as nodal metastases. And of all the patients with multiclonal disease, they found that in general, the index lesion in the primary did match with the metastases amongst those patients, and then the other remaining patients had monoclonal disease. And this is another study which was performed at Hopkins, and this one had 30 patients, again looking at genomic comparisons between the metastases and the primary. And so despite observing highly variable profiles of metastases across different patients, within an individual patient, they found highly uniform genomic profiles, and those were often matched to a single lesion within the prostate. In the radiotherapy literature, we can also see this, where studies which have had pre-radiation MRIs performed, and then patients who subsequently developed local relapse having repeat MRIs, on those comparisons between the pre and post-treatment MRIs, those dominant lesions were often the ones in which local relapse was demonstrated. And this is also shown in pathologic analyses where patients who underwent radiation, having had a pre-treatment MRI, looking at those patients who underwent salvage prostatectomy for relapse, the whole mount specimens also indicate tumor relapse within the areas which were identified on the pre-treatment MRI scans. And so the rationale for focal therapy then hinges on this index lesion driving the clinical outcomes, as well as our modern ability to identify involved areas, whether that's through MRI, molecularly targeted imaging, such as PSMA scans, and or better biopsy targeting with MRI and or saturation biopsies. And the goal is to reduce the morbidity of whole gland treatment by only treating the portion of the gland which has involvement, and then reducing the anxiety from remaining untreated for patients who, particularly those who might be on active surveillance. And so this is demonstrated from the Movember Gap 3 consortium data, which followed over 10,000 patients on active surveillance and found that, as you see in the purple, there were a significant proportion of patients who opted to undergo treatment despite lack of progression on either imaging, PSA, or biopsy data. And so there are a number of focal therapy modalities. HIFU and cryo are probably the most well documented, but brachytherapy might also be considered as an option for focal therapy. We can cover some follow-up data on focal therapy methods. So this is a large registry report from the HEAT registry of patients treated with HIFU, and a good majority of these patients were intermediate and some with high-risk disease, and they reported 7-year failure-free survival of 69%, which was defined as patients who did not have to undergo whole gland or systemic salvage therapy. They did allow for retreatment with further focal therapy, and the 7-year retreatment-free rates were 43% in this group. The rationale for brachytherapy, in particular as a focal mode of radiation treatment, would be that there are acceptable side effects, even with whole gland treatment. We have established dose response correlations and long-term control rates. And particularly with permanent seed implantation or LDR brachytherapy, we are able to easily visualize and verify dosing of the primary target volume. And potentially, if future salvage therapy is required, then one could implant the residual area without seeds visualized. So there are some preliminary reports, small phase 2 studies looking at LDR brachytherapy as a focal therapy modality. So this is a French study where they treated 21 patients with low-risk disease, as demonstrated in the table on longitudinal follow-up comparing with baseline urinary scores. You can see that there's minimal increase in the IPSS scores at 2 months, and then largely resolving by 6 months, and then sexual function scores with very little change from pretreatment to post-treatment. So they did compare with their previous cohort of whole gland treated patients, finding that there were significant differences in terms of both the urinary and sexual function compared with the partial gland focal therapy treated patients. Another French study finding very similar findings with no significant changes in either the IPSS or IIEF scores in their cohort of patients, and they performed 1-year biopsies, finding no tumors regrowth within the index tumor and only clinically insignificant cancers within the remaining untreated parenchyma. So one of the technical challenges with brachytherapy is that there can be variability of seed position on post-implant imaging when compared with where one thinks one is placing the sources in intraoperatively. These final source positions can be influenced by edema or shifting of seeds within the needle track. What this results in is that the intraoperative estimates may not reflect the final postoperative dosimetry. There can be some impact of physician experience upon the quality of implants. So this is a data set looking at over 6,600 patients undergoing brachytherapy and looking at the quality metric called D90 within those patients postoperatively. And if you graph the patient by the number of cases performed by the brachytherapist, then even though some patients were in the 300th, 400th, or 500th group of patients treated by a particular brachytherapist, you can see there's still quite a degree of variation in those patients despite the performing physician having hundreds of cases under their belt. One of the things that we've been working on at Hopkins is a method to address this problem using a C-arm within the operative suite and performing orthogonal x-rays and then performing seed recalculation with those x-rays, reconstructing that seed cloud, superimposing those seeds deformably registered onto the transrectal ultrasound image, and then being able to provide updated dosimetry of the ongoing brachytherapy dose evolution. This is an image showing comparison between the standard dosimetry system shown above and then the updated dynamic dosimetry system below. And you can see whereas the standard dosimetry system appears to show good coverage of the prostate, when we update that with the dynamic dosimetry system, we were able to identify 2 areas of underdosage in the posterior lateral aspects of the prostate and can then address that with further seeds in those locations. So we've confirmed this in a phase 2 study of 45 patients looking at the rates of what we considered excellent dosimetry, defined as a volume of the prostate receiving greater than 100% of the dose, exceeding 95% of the gland. So when we look at that V100 metric on patients on the protocol in red, and comparing with previous patients treated on standard dosimetry system in blue, you can see that there's a significant difference in the distribution, with the patients on protocol having had much higher rates of the V100 metric. One other consideration is whether MRI, which certainly is an improvement compared to previous conventional imaging, is sufficient to allow for accurate identification of index lesions and comprehensive evaluation of the extent of disease. And so this is a study which looked at preoperative MRI in patients undergoing prostatectomy, comparing that to whole mount pathology sectioning. and essentially finding that approximately 1 out of 5 patients either had their lesions entirely missed or underestimated compared to the whole mount pathology. Other studies have shown that there may be underestimation of the extent of tumor when utilizing MRI. And so MRI may not be sufficient to fully screen for patients who have disease suitable for focal therapy or for defining the extent of tumor for targeting. It appears that PSMA may be a good additional imaging method for evaluating patients for focal therapy. However, most of the PET validation studies have looked at nodal involvement or metastatic involvement to demonstrate the improvement in staging from adding PSMA imaging. However, this is one study that looked at PSMA in the context of localized disease, and they did find that tumor volume and extent compared with prostatectomy, that the PET scan was better at predicting both the number of lesions as well as the tumor volume and the laterality. So finally, our ongoing study at Hopkins is to utilize focal brachytherapy in a phase 2 study using multimodality image fusion, incorporating both targeted biopsies, multiparametric MRIs, and pilarified PSMA scanning. So we perform focal LDR brachytherapy with our dynamic intraoperative dosimetry system, and then follow up patients with MRI serially as well as repeat PSMA scan and biopsy at 2 years. So in conclusion, active surveillance can be effective, but there are meaningful rates of progression and discontinuation voluntarily. Molecular profiling studies do correlate the index tumor with that of lesions found within the metastases, and focal therapy can build on the success and experience with radiation to the whole gland, but improving the outcomes for patients with lower rates of morbidity and side effects. So thank you for your attention.